Good morning and welcome to day 2 of our summit. We're very glad you could join us. My name is Bob Twasutin. I'm a registered nurse with the ALS Association. I cover Long Island for care services, do outreach for Nassau County and Suffolk. I also run support groups and glad that you could join us today. It's my pleasure to introduce Dr. Andrea Herang-Tango, who's be talking to us about breathing a sigh of relief. And I welcome you for questions later. We will take them in the chat box and do answers at the end of the session. Welcome again. Enjoy our session and feel free at the end to give us all the questions that you may have. Those questions we may not get to, we will be back to you after the session to get those answers for you too. Dr. Harango, welcome aboard and thank you for your time today.
Thank you very much. This is the first time I'm doing this, so please bear with me. And I'm a pulmonary critical care physician at Robert Wood Johnson University Hospital and part of the volunteer faculty at Robert Wood. I do much of the ALS work with the ALS Center certified in New Brunswick, New Jersey. And I decided to look at breathing in various ways to give people a basic knowledge of what exactly goes into how you breathe, what goes on, what we look at, and what the little things that we need to be looking forward at and paying attention to need to be taken care of. So, and the first slide. You need to understand the mechanisms of breathing, and it is a pretty complicated scenario that goes on. First of all, we have a stable sternum, and that's the armor plate that's in the front of the chest. And all of the diaphragm, which is the breathing muscle down at the bottom, and the external and internal intercostal muscles go between the ribs. And as you try to breathe in, what goes on is the diaphragm tightens and the external intercostals contract. With that, the chest increases its size and it allows negative pressure to happen to expand the lungs. When you relax the diaphragm and the external intercostal muscles, that causes a recoil, and that allows us to blow the air out so that we exhale. If we want to force exhale, then we need to use the internal intercostal muscles to contract as well. And again, this is where the sternum is, and the diaphragm inserts along the bottom of the costal margin, and the external intercostals are between the ribs here, and the internal intercostals are along this edge. The other thing we need to understand is what goes on with ALS. And this is just basics because you are probably hearing this from someone else, but it is an upper motor neuron degeneration in the motor cortex, which is up in the brain. And what happens is you get deposition of protein aggregates that form inclusion bodies in each one of the neurons. When you have this happen, the neurons degenerate. They also release various neurotransmitters, calcium into the connections between the upper motor neuron and the lower motor neuron. And with that, there is stimulation and abnormal stimulation of the neurons, which are lower, which lead to the muscles either up in the face or the tongue, or into the skeletal muscle if you're following the nerves that are going down along the spine. We have to understand what shortness of breath is. Shortness of breath, another word for it is dyspnea. It is a balance between the supply and demand of oxygen. All right, so what does that mean? Well, how do we supply oxygen? The first thing is oxygen is in the atmosphere around us. So at the top of Mount Everest, there's not enough oxygen in the atmosphere. So everyone wears oxygen at the top of Mount Everest. The next issue is, does my chest wall move? Do I have scoliosis or kyphosis, where my rib cage is crunched together and I can't pull the air in? Or the other thing is, does my diaphragm and my intercostals work to be able to pull the air in? And then when we relax, allow it to exhale. The next issue is, do my lungs work? Basically, you have your windpipe, the airways branch like the branches of a tree until you get down to the air sacs. The air sacs are surrounded by the blood vessels. And if I take a cross section, it's 1 cell layer thick for the air sacs, 1 cell layer thick for the blood vessels. That's where the oxygen goes back and forth between the lungs and the bloodstream. So that's a normal lung. So not everyone's lungs are normal. Some people have asthma, and asthma is, there are smooth muscle cells around the walls of the airways here, and they clamp down. And the other half of asthma is you get inflammation. So you end up breathing through this little area instead of the whole area that would normally be open. If you have emphysema, you were a smoker or someone around you smoked a lot, these are the same air sacs, and they're kind of like the foamy soap that you wash your hands with, tiny little bubbles. With emphysema, all those tiny little bubbles coalesce and end up with this one big bubble. It's kind of like blowing a soap bubble when you're a kid using soapy water. So what happens under those conditions is you lose the walls, and therefore you don't have the surface area for the oxygen and carbon dioxide to go back and forth. Last kind of problem that you can have, and this is very simplified, is you can have diseases that scar your lungs or cause inflammation. And these are cuts through the lung via a CAT scan. The black is air, so your lungs are filled with air, so they're black. White is bone, so your rib cage is around the outside. This is your backbone. And so your lungs are supposed to fill with air, and this is your heart. This is close to normal, although back here, you start seeing there's something going on. And as we progress in this person's chest CAT scans, what's going on is they're getting more and more scarring, more and more fibrosis, so they cannot get the oxygen back and forth between the lungs and the bloodstream. The other thing that happens, some people get pulmonary emboli, which cuts off the blood supply going through here. And if you don't have blood flow, you can't get the oxygen back and forth into your bloodstream. So what happens after you get the oxygen into the bloodstream? Well, your red blood cells carry oxygen. So all these red blood cells will take up the oxygen in the hemoglobin. But if you have anemia, you have a lower likelihood or inability to carry as much oxygen. What's the next issue? Well, your heart pumps those red blood cells around. So the first question is, how strong is the heart pump? Is it normal? Is it not normal? The ejection fraction is supposed to be between 60 and 65 normally. The next issue is, does it fill properly? If your heart does not fill properly, if I only fill it halfway, I need twice as many pumps to go forward. The last part is valves. Are they leaking? Are they too tight? If they're tight, you can't pump the blood forward. If they're leaking, the blood goes forward and comes back again. So that's not going to be as efficient as it needs to be either. What goes on from the heart? You can have narrowed arteries. If you have narrowed arteries, you cannot deliver the oxygen to your muscles. And then finally, you can have abnormalities in the muscles or the mitochondria. Those are weird things that only us pulmonologists should need to know. All right, so what happens to the demand area? Well, if you're 100 pounds, it takes less oxygen to do the same amount of work as if you're 300 pounds. If you're burning up with fever, you're burning more oxygen. If you've got a huge tumor, you're burning more oxygen. So as soon as you outstrip supply demand, that's when you get winded. So those are the things that we have to pay attention to about what causes individuals to get short of breath. And with ALS, a lot of times, because you're weak as far as your muscle strength, sometimes to be able to pull the air in, we outstrip our ability to keep up with what we're doing. If you think about it, someone who is running a marathon, they're breathing fast. So if you can't pull that quickly, then you won't get the oxygen into the lungs the way you need to. How do we measure how the lungs function? Well, what we do is we do pulmonary function tests. And what we have you do is normally breathe in and out, and then take a deep breath in, and then blow it out slowly, and then breathe in and out, and then take a deep breath in and blow it out hard and fast. That's the forced expiratory volume versus the vital capacity, which is just slowly blown out. When we look at your muscle strength, this is the maximal inspiratory effort. So we measure it from the end of breaths. So we have to see how well you pull in. So you can't pull in on top of a full lung. So the lung has to be empty. So we measure from the vital, the FRC, or we measure from the vital capacity. And when you're at that level, we have you go, and we see how strong a breath you can pull in, or what kind of pressure you can produce. And then with expiratory pressures, you can't expire unless you're full of air. So we need to have you breathe in deeply, as deep as you can, and then we have you push out, and we see what your expiratory pressure is like. The lower limit of normal inspiratory pressure is 60, minus 60 for women, and minus 80 for men. And the normal lower expiratory pressure, so that becomes a positive pressure, is 120 centimeters for women and 150 centimeters for men. And as I said, they're measured from different points on the pulmonary function tests. So when we breathe, we pull the air in, and then we are allowed to exhale. So to get a full tidal volume in, it takes minus 12 pressure. So if I push plus 12 pressure into you, then I can fill your lungs with air. You can breathe in through your mouth or through your nose, and these are some of the ways that we help you breathe in. If you can have your mouth closed, we can use just a nasal pillow or nasal mask. And what that does is it pushes the air in. If your mouth is open during that time, it short circuits and comes right out of your mouth. So that's why sometimes we need to use a mask that covers both nose and mouth. This is some of the way that we do our breathing with various types of machines. And the other thing I wanted to talk about is a cough assist. Many times people do not have the strength to be able to give enough of a positive pressure to be able to cough and get the mucus out. Sometimes people with ALS have problems with too much saliva, and they have trouble controlling where the saliva is going. So one of the things that we do is we use a cough assist device, which will apply positive pressure to push air into your lungs, and then the device switches to a negative pressure to suction the air back out. And what that does is it allows you to strengthen your diaphragm, keep your lungs clear, and reduce the chances of infection. If you are unable to clear the mucus, if you think of your hand like the branches of a tree of your lungs, if you plug up here, right here, then that area of your lung can collapse down, and that area of your lung will not work anymore. So that's why it's so important to keep everything as open as possible. Okay. Now there's various types of ventilators, which are machines that help us do breathing for you if you cannot do your breathing yourself. I don't know how many of you know or remember or have heard of the iron lung. Back when they had polio, what happened is they would place individuals into an iron lung, only their head would be out, and the container here would be set for a rate and a negative pressure. So that negative pressure, when it came on, would force you to breathe in through your mouth, and then it would allow you to exhale, and then you would exhale again spontaneously. because that is a recoil. It's not, you don't need to force the air out. When I was a fellow, they put us all in an iron lung so we can feel what it felt like to be ventilated with one. And it's interesting because depending on the size of your chest wall, if your chest wall is thinner, you need less pressure to move it than when you're heavier. So when I was put in after someone who was a little heavier than I was, and I got hyperventilated because they left the settings the same way. This is what's called a cuirass, and that you can still get nowadays. It's called a turtle shell, and it goes across the chest and straps onto you across your back, and it can pull the air in and allow you to exhale. As you can imagine, it's not going to give you the same amount of negative pressure that something like this does, but it does do enough of that. The other thing is it can produce a cough assist kind of pattern where it can help you loosen up the mucus. These are the more routinely used types of products, and basically they're positive pressure ventilators, and you put on a mask or either a nose or nose and mouthpiece mask, and you can set either pressure or volume. You can set rates. Now, if I give you enough pressure, you will get a volume, or if I give you a certain volume, you will hit a certain pressure. So it's just semantics about how that is set up. And to tell the truth, usually we like to be more reliable about the volumes that the individuals get with the set rate. And sometimes if you get weaker, you can't set your own rate anymore. So we have to dial the rate up to match what your needs are. This is called a Voxin, and one of my patients taught me about it. Basically, it's a very compact multi-device. It's a ventilator, oxygen supply, cough assist, suction, and nebulizer all in one. It's 18 pounds, and it makes it easier to move from one mode to the other, so it's more compact and easier for travel and things like that. And most of the time, the payers do cover it for people with ALS. So if I can breathe for you through a nasal mask or and full face mask, why do I need to put a tracheostomy in? Well, a tracheostomy, first of all, let me explain what it is. And it is a tube that goes in through the front of your neck and into your trachea. All right, here you have your windpipe and your esophagus are right next to one another. And so one of the things that we end up having a problem with is if you cannot control your secretions, the secretions can go down the wrong way and end up in your trachea. Now, sometimes we need to suction individuals, and as I said before, we use the cough assist device. But if someone has too much trouble with their secretions or too much trouble with the aspiration, or they end up not being able to breathe for themselves and we can't get them off of a ventilator, sometimes we switch to a tracheostomy tube. Think about it. This is your neck right here. And if you feel your windpipe moving when you put your finger here. So it's just skin and then your windpipe. So it's very easy to put in. They make an incision in the skin, an incision in the windpipe, and put this tracheostomy tube in. This is the tube I'm talking about. They put this into the center of the tube, so it's a blunt end. When we put it into the trachea, then we take this out, and you end up having this kind of, this is the inner cannula, this is the trachea. The end of the trachea has a balloon on it that you blow up with this that stays outside the individual, and it will seal the upper from the lower airway so that you can give all the breathing through that. The thing to remember is this tube is smaller than the windpipe that you're breathing through. So if you have a tracheostomy and you have neuromuscular weakness, chances are you won't be able to breathe on your own, The best we expect is to be able to have you off the machine during the day and on at night, but that's only if you're mildly decompensated. If you are on a tracheostomy or have a tracheostomy and need to be on a ventilator 24 hours a day, that means you have to have 3 sets of individuals caring for you, because one person cannot be awake 24/7 and make sure that you don't get into trouble. And that becomes a problem. And so that sometimes is something that is a difficult decision for individuals to make. The other piece of equipment that I'd like to talk to you about is a gastrostomy tube. There are 2 reasons that we use a gastrostomy tube. I talked to you a little bit about your windpipe and your esophagus being right next to one another up here. If you think about how you eat, the first thing you need to do is chew. So if these muscles here are not working properly, you can't chew properly. So you need to chop up the food. The next issue is getting your food from the front of your mouth to the back of your mouth. So if your tongue is not working properly, that is a difficult thing to do also. And then the final thing is, if your muscles in your neck don't work properly, then the food can end up going into either tube. And so that can cause a problem. So one of the things we do is we use a chin tuck or thicken liquids to make sure that the food is tending to go down to the esophagus. If you can't keep up with your nutrition, yes, we suggest having a feeding tube if you want one to be put in. All right. The other reason that we use a feeding tube is if your lung function is getting worse over time, then it becomes more difficult to do procedures. And if it's more difficult to do procedures, doing a gastrostomy tube becomes more dangerous, and you may end up being on a ventilator. So as pulmonologists, we'll talk about a gastrostomy tube earlier rather than later if there is progressive respiratory worsening. How is this put in? Again, this is your skin, a little fatty tissue, your muscle, your stomach. If any one of you has had an endoscopy, they look inside your stomach. You can see the light in the stomach through the wall of the abdomen. So if you think about how thin that is, it's not that thin. I mean, it's not that thick. So what they do is they clean your skin off. They give you a numbing medicine. They put a needle in. Through the needle, a wire goes in, the needle comes out, and over the wire, the feeding tube gets put in. That's it. It's not complicated. I tell people it's kind of like getting a pierced ear. No, you don't necessarily want one, but if you need one, there's not much of a conversation to be had about whether you do or don't want it, if you want it. The next issue that I talk to my patients about is code status. What does that mean? It means, do you want to have everything done? I am trained to do everything in my power to save your life, whether you like it or not. All right. And usually that makes people laugh because, yeah, of course, Dr. Harangozo, why wouldn't you want to have everything done? Well, it's all about your value system and what you are willing and not willing to go through in your life. And so some people are okay just watching TV or having their grandchildren visit them. Other people are not happy unless they go out and cut down a tree in the backyard. It's very, very personal. Just because I can do something doesn't mean I should do something. And I call people out on the fact that if you don't give an answer to the question, that means you want everything done. And that's fine. That's going to be what happens. The thing I also point out to my patients is, as much as you would do for your family and friends, they want to do for you. And you are your loved one's emotional support, even if you rely on them to care for you. So don't ever underestimate that. Always live your best life through it all and enjoy every minute of it, no matter what's going on. The only thing we can control is our reaction to the world around us. And it's about us deciding how to live our lives rather than anything else. So thank you.
Let me take myself off mute. I just want to start with one question until we get a few in the question and answer box. But what would you advise patients for early signs and symptoms that they should notify their team that things are not transient anymore, but recurring more? And then what would be signs and symptoms that persons or families should consider calling 911 because they're of a different magnitude and urgency when it comes to respiratory?
One of the things I would hope that your doctors are in good contact with you. What we are doing pulmonary function tests, shortened version, just the spirometry and the muscle strength every 3 months. Usually we know whether someone's getting into trouble or not. And oftentimes we're the ones talking about gastrostomy tubes and the hypersalivation and ways to control those things with our patients before they start getting into trouble. Of course, if there's any question about life-threatening situation, you call 911. That's a given. We're 24/7 available. And the thing is that we can't do anything oftentimes over the telephone. So it oftentimes becomes the default that you should be reaching out for 911. But if you're having trouble breathing and you have a ventilator, you should put the ventilator on. If there's problems with clearing of secretions or something along those lines, you should be using the cough assist device. You should be using the suction machine. Of course, using gravity if you need to bend over or turn over to try and clear something that may be in the throat. It doesn't matter where it goes as long as it comes out of your lungs. So I even have said, just get the bucket and whatever comes out, so that people are okay.
Okay, we have a few questions that have joined us now. One person's asking, when you have a trach, can you address your ability to speak when trached and what type of devices that you might use when trached?
With the tracheostomy, there are certain devices, the Passy-Muir valve, which allows the air to go in. It's a one-way valve on the trach. So the air can go in one direction. And then if the person's lung function and their body habitus is adequate, then you can allow the air to come back out through the mouth. Most of my patients with ALS don't do that. I do have someone who's got a spinal cord injury that's capable of speaking and timing the speech. Basically, you need the air to go in, and then when it's coming out through the mouth, that's when you can speak. So you have a timing thing that goes on.
Very good, thank you. And another question came up is that, can you explain why patients are told not to use oxygen versus the different devices that are most often recommended through their clinics for ALS in particular?
Well, the issue is the oxygen is not the problem. The problem is that you're not getting the air into your lungs. That's the problem. And if you use oxygen, there's something called microatelectasis, which the tiny little alveoli can collapse down. So it doesn't fix the underlying problem of taking the air in and exhaling it. So oxygen's just basically a bandage. If I put oxygen in front of me and I can't get the air in, it can blow as much as it wants. It won't fix the problem. So it's kind of avoiding the underlying problem that we have. The last thing to go is your oxygen level. So watching the oxygen saturation doesn't really give us an indication of what your breathing is like. That's why even when we do pulmonary function tests, the negative inspiratory pressure and the positive expiratory pressure is the best way to tell how strong you are or are not.
Okay, very good. And another question basically was about how does stress and anxiety affect sometimes your oxygen levels or your use of these equipments?
Well, stress, if you think about it, if you have severely compromised muscle strength, then one of the things that goes on is you're trying to pull air and it's not moving. Or the other thing is, if you have significant weakness of your upper airway, extrathoracic weakness, then what happens is as you make negative pressure, you're pulling the airway closed. And so the more you're stressing, the more you're closing the airway, and that can make it feel even worse. What you do is using a positive pressure way of pushing the air in should relieve that feeling of not being able to get enough air.
Very good. Two additional questions. One would be, what effect has COVID had on people with ALS and their lung function?
Well, COVID has given a lot of people problems with their lung function. The issue more for the ALS patient is the fact that they can't really clear their secretions if they're compromised in their respiratory function. And if you can't clear the secretions, you get mucus plugging. And as I said before, if you get mucus plugging, you end up losing more and more of your lung function. And then the question is, can you get it back? Can you clear the mucus? Again, and this is why this conversation about code status is important, because do you want to be on a ventilator where we suction you and do it ourselves through the tracheostomy tube? One of the things I didn't say is if you're having a lot of problems with secretions, it's easier to take care of through the tracheostomy. But again, not everybody wants to live with a tube in their throat or live that kind of life. Now, I have someone who has a tattoo that says unbreakable on their arms, and they're on a ventilator and they're living their lives fully. So I want you to live your lives fully.
Right. Probably two questions related again to the tracheostomy.
Yeah.
One says, if I'm trached, what can I do if I decide that I no longer want to be trached?
So you can choose not to go back on the machine. I said sometimes people can be on and off of it, and you can choose to withdraw support. I will tell you that as a pulmonary critical care doctor, it's a very difficult thing to deal with. I didn't mention New Jersey is a state where you are entitled to end your life also. And that goes to everybody's value system, be it your physicians or yours and everybody's. And so to remove someone from a ventilator is a difficult thing to do because that individual is totally intact and their brain is functioning and they're looking at you saying, stop this. And in my value system, it's a lot easier for me to say, don't go on it to begin with. And that's why I start the conversation the first day I meet anybody, even if the only problem is I have a little weakness in my hand, because these conversations need to be had and need to be processed. I've had a patient, a couple who came in who the patient wanted to end her life and she never told her family. And I told her she's not done with her life because she has to have these discussions with her family before anything else happens. And there are individuals in New Jersey who do deal with end-of-life conversations, and that's under the Department of Health. You can get information about that.
And somewhat related again and again with the early discussions about a trach, if you're sure you don't want a tracheostomy, how do you make sure you don't get one if you're taken to the ER?
You should be filling out a POST, which is physician orders for life-sustaining therapy. And it's a green sheet. God only knows why the state has decided on green sheets, because nobody carries green paper in their office. But what it does is it says, I would like, what would I like? I will, if you'd like, I will pull that up. Just try to get it. Sorry, guys.
And another one talks about pressure settings for cough assist and NIV, who sets them and how often is that checked and changed?
So those cough assist settings are set usually starting out low, as I wrote, 10 to 20, but it can be 30 to 40 to 60 pressure, positive and negative. And it depends on what the individual is comfortable with. And so if it's not enough for an individual, then you just contact a doctor and we will change it.
Right.
Respiratory
just,
therapy usually does that.
And just to kind of to reiterate on the same question we had earlier about making decisions that you don't want as you're going to the hospital or ER in New York, you would be filling out a MOLST, M-O-L-S-T. Can be done
No,
with your
P,
social worker.
pulse,
With your,
pulse.
right. In New York State, it would be a MOLST.
Oh, okay. All right.
Just a very similar form, just acronym differently, but always should be stating your intentions, whether it's for
Right.
coding, whether it's for different devices. It gives clearer instruction on how you want to be managed. Yes,
absolutely. So what I'm trying to pull it up for you to be able to see it better. All right, let me see if I can share this with you. All right, so I think you can see this, although it's small. But basically, it talks about your goals of care to begin with. So I usually talk to my patients, and it's usually I would like all normal medical care short of heroic measures. If someone's making me fill this out, they usually have some limitation. And then the next question is, do you want full treatment? Again, usually that's not the case. Limited treatment, including or not including the hospital. And then the next part is whether or not you want to be resuscitated. And resuscitation meaning doing chest compressions and breathing in and out of your mouth. And then the other thing is to put a tube in to breathe for you. So usually when we're having this conversation, people don't want their heart restarted with electricity and they don't want a tube put in. Depending on whether you wanted to have a feeding tube or not is the nutrition. And then whether you won't trust your caretaker to be able to just make changes in those things for you. So that's what the pulse or MOLST is.
Right. Now, one more question with the trach patient. What happens if a trach patient gets locked in?
Well, then it's up to the caretaker to decide what they think their loved one wants.
Okay.
So if the individual doesn't want to live that way, then that individual needs to be communicating that to everybody around them. Again, right now we've got the Toby devices, so usually people can use their eyes to type out what they want. So the communication is much better nowadays than it was 10 years ago, 20 years ago. But locked in that's the reason that we have these conversations ahead of time.
Exactly. And it is important to have conversations with family, those people that are included in your healthcare proxy, and those that will be assisting you with those decisions so everyone's on board and can understand your best wishes going forward. Another person is asking about pressure settings. Is it something the caregiver should know, or do you just call the rep that's servicing your respiratory equipment to check it out?
The settings, it's always good for you to know what settings you're on. That's the bottom line, so that you can communicate that with any physician that you're talking to that would possibly need to have that information. The issue is that it's usually adjusted by, and it's about what is comfortable for you. And as I said, some people, if I take a negative pressure of 12 in, I get a full tidal volume because I have normal lungs. If I'm someone with emphysema, I may only need -8 or +8 pressure in to get a full tidal volume because the lungs are much more expanded when we push the air in because they're more elastic. And so the pressure is not as important as the volume that the individual needs. The other thing is the pressure may change if you have pneumonia or mucus plugging. The other thing that happens is if you're turning an individual, just pressure may decrease the amount of volume because you turned you on your side. So you have to be careful about making sure that the volume stays adequate for the ventilation of the individual.
Okay. And another person asks, when using a pulse oximeter, what would be a red flag? Would less than 90 be a red flag, or is there another indicator?
Well, as I said before, I don't tend to use a pulse ox on my patients. We use muscle strength and shortness of breath. The pulse ox for any situation should usually be above 90%. When you start going below 90%, then you start getting into situations where you're getting a little less oxygen to your tissues. 85 is the end stage COPD patient. I don't like there. I always like my patients above 90. But again, that's not what you should be following. The question is, do you need to be on a machine to help your breathing or not? And if you're usually running 98, 97, and you're now running 92, something's up, something's not right. So the decrease from your usual is basically what the question is, rather than a specific number.
Right. Again, I guess related to the tracheostomy, is it possible for someone to be extubated at home?
In what setting? Are you talking about terminal extubation?
They haven't clarified. They've just left it as general. I think in most general terms, you're going to be done in a facility while you're being observed.
Well, the issue, yeah, the issue is why is the person on the ventilator to begin with? Right. And why are we talking about extubation? If someone can be extubated, that person is usually extubated in the facility they're being cared for, if they can be. And to tell the truth, if you're extubating someone and want them to survive, then you need them to be around medical professionals who can decide whether they are safe or not safe at the time post-extubation.
Exactly, I would agree. Another question would be on, again, cough assist. I often cough with my saliva, and at times it makes it hard for me to breathe with a cough assist. Help me with that. Yes,
that's one of the reasons that we use the cough assist. And then the other thing is we should be treating you for the excess saliva. So one of the things we use is scopolamine patches. The next thing usually is glycopyrrolate. I've had patients use Benadryl if they didn't get sleepy with it. You can use Botox injections into the salivary glands that usually last for somewhere around 6 months. And then some people have had radiation to their salivary glands as well. And then amitriptyline has been tried also. So it all depends on the individual and how well they respond to the treatment.
And along with the cough assist, is there a minimum time that people should use it on a daily basis for greatest benefit?
You should be using it at least twice a day, even if you feel like you don't need it to clear secretions. And 6 cycles twice a day is a reasonable thing to be doing to get some benefit for strengthening of diaphragm.
Very good, thank you. And let's see, I think one person has asked, can you just give a little further explanation about the combination device that we talked about earlier?
The Voxin. Basically, it has the different modes that you can use, and it can flip between the different modes that you're using. So if you're on the ventilator most of the time, but not always, you just hit the button to switch from ventilator mode to cough assist mode. And then you flip the button and then you get the suction going immediately after the cough assist. So it's all in one, and it's 18 pounds instead of here's the suction machine, here's the ventilator, here's the cough assist device, which ends up being a whole back of the car trunk filled with equipment rather than this 18-pound piece of equipment.
Right. And the Voxen would be spelled
VOCSN, Voxen.
okay, very good. That same person had just asked that question. Okay. And let me just see, we have a couple last few questions. With people with excess saliva, have you used or have you had any recommendations if they should use CBD gels versus some of the other medicines that you recommended?
I've heard that some of my patients have benefited from it. If it works, that's fine. I have a good number of my patients using various forms of CBD or whatever format of medical marijuana, and they do better. They have a better appetite, less myalgia, which is pain in the muscles. You always have to look out for that as well.
Sure. And we have just, I think, an additional question basically asking about, can we explain what locked in exactly means?
So locked in means that the individuals, all of their muscles do not work at all. And so they're on a ventilator, and the only way that I am able to communicate, if I am, is blinking. One blink for yes, two blinks for no. There's no movement of the head, the neck, nothing. So you're locked in because people can't tell whether you understand or not understand, or you cannot communicate in any way.
And I guess it's a similar question. What % of patients get locked in?
Not many. I think in my career, which I finished my fellowship in 1990, I think of one individual that was so completely locked in that I could not communicate with them.
Right. And I guess one generalized question would be, when you are prescribed respiratory equipment, what type of adjustments should you expect as you're starting to use equipment, being this pressurized oxygen versus a nasal cannula? What type of things should you just know that it's going to be a transition, and how do you make that adjustment work best for you?
Again, you're talking about oxygen, which I do not use in ALS.
Right.
So
Right.
I don't know where that is coming from, if someone would like to call my office. But we use the pressurized either. So there's BiPAP, which is 2 positive airway pressures. And then there's these ventilators, be they pressure or volume regulated, set a rate and set a volume, set pressures. The BiPAP basically senses flow. So you have a higher flow, which will push the air in, cuts to the lower pressure, allows you to exhale. When the flow stops, it kicks to the higher pressure, allows you to breathe in, kicks to the lower pressure, allows you to exhale. When I'm taking care of ALS patients, I try to automatically just go to getting them a ventilator, suction apparatus, and cough assist device. And usually the Voxen is what we use unless there's a major insurance problem. So we go straight to that because there's no reason to be changing pieces of equipment. It's if you are going to be deteriorating, then there's no reason not to go with the one that you're going to need, rather than play around with, well, we'll do this first, and then we'll do this, and then we'll do that. It just gets things complicated.
Very good. We've had some excellent questions. I think they've ran the gamut of different concerns. Are there any other questions while we are together that we can answer at this last moment? I do have one generalized comment that thank you. It was a great presentation, much appreciated. I believe it's the same thing. It was very comprehensive. The questions were very detailed and very easy to understand. And as the doctor says, always be in touch with your team. Talk with the physicians that are managing your care. Notify them as changes are occurring so that they can help to assist in between your 3-month appointments. We want you to be comfortable and feeling as best you can during those periods. Don't wait for the appointment time itself, unless it's just before the appointment, but very important to keep in touch. I have one last question, I believe, that says we have NIV, but no suction. Is suction necessary at the start?
If you can get it out of your mouth, you don't need suction necessarily.
And I have another one basically saying, basically live your life to the best. And that we would encourage always. That's our role as a team, as a care team, to help you to enjoy and live every day to the fullest and to make this journey as pleasant and as most enjoyed and as most that you would expect from things.
Don't forget that many times it's a husband and wife that are caring for one another, and they should remember that they are husband and wife in addition to caretakers, and don't lose that part of your relationship.
Right. One last question, I think it's fairly simple. They're asking, just with the Voxin, does it also replace the cough assist? And I think you mentioned that it integrates it as one machine.
Yes.
Very good. Let's see if we have anybody else. Many people have just sent in many thanks. So I think it was a very topical conversation, one that impacts everybody in so many ways, whether you're a patient, a caregiver, or a friend, or a clinician that's working with our persons with ALS. So much appreciate your presentation today. I believe we'll be wrapping up, and please stay tuned for the next session, which will be talking about ALS with family, friends, and your workplace. Thank you for joining us.